Good morning, friends. I'm Preeti Rajesh. Practice of dry needling in physical therapy. Coming to a history, definition, and terminology of dry needling. History. The origin of dry needling are drawn from Western medicine, principles, and scientific research based conclusions. The technique of dry needling has no historical ties to acupuncture, which is based in Eastern tradition. Pioneers Dr. Janet Travell and David Simmons in the early 1940s. The wider use of dry needling started after a study in 1979 by Czech physician Karel Levitt. From origins in wet trigger point injections performed by physicians grounded in Western medicine to the use of a dry fine filament needle by specialty trained physical therapists, the technique of dry needling has had a fascinating evolution. Coming to the definition, a skilled intervention that uses a thin filiform needle to penetrate the skin and stimulate underlying myofascial trigger points, muscular and connective tissues for the management of neuromusculoskeletal pain and movement impairments. Types: there is superficial dry needling and deep dry needling. In superficial, it penetrates to the superficial layers of the skin and thought to activate mechanoreceptors coupled to slow conducting unmyelinated C fibers efferents and indirectly stimulate the anterior cingulate cortex. While in deep dry needling, it penetrates to the deeper layers of the skin and has been shown to inactivate TRPS by eliciting local twitch responses which are modulated by the central nervous system. Is dry needling acupuncture? This is the common question we are facing daily. So, in dry needling effectively treats musculoskeletal pain and dysfunction, while acupuncture aims to influence energy and meridians. The only similarity between the two is we are using the same tool, it's a fine needle. So, depending upon the tool or as the tool is common, it should not be never define the profession that uses it. Dry needling in physical therapy. It includes subjective and objective evaluation of the neuromuscular system, insertion of the needle into trigger points based on assessment and knowledge of neuroanatomy. So what do the dry needling do? It increases the range of motion, it increases the blood flow and decreases the banding locally or in segmental muscles and improves the ability of muscles to move through range. Also, it decreases the pain, deactivate the painful trigger points, nociceptive sensitizing agents, decrease banding or compression of adjacent tissues, segmental inhibition, and effect on central mediators. It also restores the function by restoring the length-tension relationships and improve somatosensory mapping. Procedure of dry needling. There should be the points we are going to discuss is the criteria for patient selection, role of physical therapist, therapist knowledge and training, general protocol and guidelines. So regarding the criteria for patient selection, dry needling is appropriate for nearly all patients who present with any of the indications for dry needling. Patients must recognize the physiotherapist must recognize when patients present with significant needle phobia or other anxiety about being treated with needles. PTs must decide on an individual basis whether a patient with needle phobia or significant anxiety is an appropriate candidate for dry needling. So if the patient has a needle phobia or if showing too much anxiety or if in a denial state, I don't want dry needling, better leave the patient. No need to force him to do that. Patients must be able to communicate with the physiotherapist either directly or via interpreter and that they must be able to consent to the treatment. Caution is warranted with the younger patients. So it's ideally to leave the younger children below 12 years of age. But if we have to give the dry needling, it should be only performed with the parent and child's consent. So the child should be aware of the procedure. Indications for dry needling: restriction in range of motion due to a contracture of muscle fibers or taut bands or other soft tissue restrictions such as facial adhesions or scar tissue. Myofascial trigger points which may lead to impairment in body structure, pain and functional limitations. Myofascial trigger points, if we are saying, it can be focal trigger points or latent or satellite trigger points. So physiotherapists should have a good knowledge of the trigger points, how to recognize it. And the trigger points itself, it is a generalized one. It can be, the trigger points have been identified in numerous diagnoses such as radiculopathies, joint dysfunction, disc pathologies, tendinitis, craniomandibular dysfunction, migraines, tension-type headaches, carpal tunnel syndrome, computer-related disorders, whiplash-associated disorders, spinal dysfunction, pelvic pain, and other urologic syndromes, complex regional pain syndromes, nocturnal cramps, phantom pain, etc. So, in all these cases, dry needling is effective. Coming to contraindications and precautions for dry needling, absolute contraindications. As we told, needle phobia or unwilling patient or unable to give consent, like age related. If the very old patients, it's better to avoid, or the patients who cannot communicate, or if they are the cognitively disabled ones, better to avoid. Better no, it's an absolute contraindication. Again, history of reaction to needle in the past. Patients on anticoagulant therapy or with thrombocytopenia where hemostasis by palpation cannot be carried out appropriately, it's an absolute contraindication. Into an area or limb with lymphedema, as patients with lymphedema may be more susceptible to infection. In addition, it is not advisable to needle a limb after surgical lymphectomy. So, lymphedema and after the lymphectomy, both is an absolute contraindication. Then relative contraindications like abnormal bleeding tendency, compromised immune system, vascular diseases, diabetes, pregnancy first trimester, frail patient, epilepsy, allergy to metals or latex in gloves, psychological status. So these conditions, it is not absolute contraindications. If we can modify the situation, a dry needling can be given, especially in diabetes. Most of the patients coming to us are diabetic. So in this condition, if the diabetes is under control, in that case we can give. Or epilepsy, they are taking the medicine, or an abnormal bleeding tendency, they are taking, they are on proper medication, or in immune system compromised patients also, if they are on medications, and we should have the proper knowledge about the patient's history, then only give the dry needling. Things to remember before dry needling. Role of physical therapist. Examination and evaluation are completed and clear therapeutic goals and objectives are established. Risk assessment and screening for contraindication. Always thoroughly explain about the dry needling and its procedure. Therapist must take the consent from the patient prior to dry needling. Comply with the principles of safe practice. The patient should be educated in appropriate self-care techniques post-dry needling treatment. Protocol for dry needling. All patients must be screened for contraindications prior to dry needling. Therapists must ensure appropriate screening through the medical record of the patient and to rule out the contraindications and precautions to be taken prior to dry needling. On arrival, patient must be appropriately briefed about the dry needling, its procedure, possible side effects and expected outcomes. Therapist must perform hand washing, alcohol rub and use personal protective equipment. Therapist must stay with the patient all the time during the treatment to ensure maximum safety. So after pricking the patient, don't leave as such, the therapist should be around. Therapist should report accidents and incidents and should follow the incident reporting policy. Therapist must dispose the used needles in appropriate puncture-resistant containers located as close as practical to the area in which the items were used. So follow the proper sterile methods and dispose the used needles in the sharp boxes. Post-treatment, re-evaluate the patient. Stretch, passive range of motion, active range of motion should be done, either passive or active. And instruct the patient in self-mobilization techniques, cold application to avoid muscle soreness in acute phase and heat in case of subacute to chronic conditions. Movement facilitation, tape also can be used, like kinesio taping can be used. So after the treatment, it's not to leave the patient as it. Don't instruct the patient as the needling is done today, take rest. It's not like that. Should give stretching techniques and teach the patient self-stretching techniques and active range of motion exercises, and tell the patient that can expect some body soreness, and in that case can use either hot pack or cold pack, and also taping can be done. General guidelines for dry needling. Safe dry needling practice include the knowledge and skill to perform the technique. Physiotherapists should be able to demonstrate they have received suitable dry needling training. Therapists should complete a physiotherapy assessment prior to dry needling and ascertain if dry needling is suitable for the individual patient and the condition to be treated. Therapists should practice dry needling in a sensible and reasonable manner and apply professional judgment. Therapists should consider the utilization of dry needling in the light of evidence-informed practice, scientific research, clinical reasoning, and patient goals, beliefs, and desires. So, dry needling, whether to perform the needling or to not to do on the patient, it is individual. It depends on the person to person and the condition to condition. It depends upon the knowledge and skill of the therapist. Adverse effects. Dry needling, even if it doesn't possess potential harms, not serious harms, there are some adverse effects, as it is also an invasive treatment, as it is an invasive procedure. So first one is a pneumothorax. Dry needling may puncture pleura and cause pneumothorax. Dry needling should be performed with special precautions around thorax. Needling is done obliquely and superficially. Always for the thorax region rather than vertical dry needling, it is better to do oblique and superficial dry needling. And also a pincer grip in case of doing for the upper trapezius or in the thorax area, it's a pincer grip to lift the fascia is better, and then do the pricking. The risk of pneumothorax is very small if proper dry needling techniques are employed. And if the pneumothorax, these are the clinical features. Patients may show sudden and sharp chest pain, breathing difficulty, tight chest, early fatigue, tachycardia, diminished chest sounds, low O2 tension, and low BP. Other adverse effects are on blood vessels or nerves. Dry needling may cause injury of the blood vessels. Palpating for a pulse to locate an artery prior to dry needling minimizes the risk. Next, on nerve, the same thing. It's a potential injury potential for injury to the nerves. Special consideration needs to be given in the relation to the spine and in the posterior suboccipital area. Again, organs. Anatomical knowledge of internal organs is important. As with dry needling, there is potential for injury to internal organs such as the kidney or penetration into a peritoneum cavity. These all are very less. These are chances for this kind of puncturing the artery or nerves or penetrating to organs are very less, but these are the adverse effects of dry needling. Then other things that stuck, bent, broken needle or forgotten patient. So when you are doing the puncturing, if there is any obstacle, you feel like any hard area you cannot puncture more, better leave it there. No need of piercing more deeply, and always be near to the patient. And if there are many needles you are doing the needling for many areas, should take a count and remove the needles without forgetting any. These are my references. Thank you.